Hello, everyone.
Hey, Randy.
Hello.
Okay, it is 3:01. Let's go ahead and get the meeting going. And we'll do roll call. Excuse me. Valerie Richards. Valerie.
Oh, I'm just
Then
turned on
Lindsay.
my audio. Sorry about that.
Oh, there you are. Okay, Valerie's here. Linda Winstanley.
Here.
Julia.
Here.
Hi, Julia. Grant.
Here.
Linda Whitney. I see you. Miranda Robinson.
Here.
Don't see yeah, she's here. Miranda, you're here.
I'm here. Yeah, I'm here.
Yep. Okay. Amber.
She's admitting right now.
Amber.
Well, she's been trying to admit for a while, but it's not. It just keeps
Or when
saying
she gets
admitting
on.
for her.
Okay. Seamus.
What do you want to say to Aspen?
Seamus, I saw you. Yeah, you're there. Seamus, you there? Well, I see he's here, but no, now he's leaving. Anyway, let's go ahead. Commissioner Thompson is out this week or this month. Jill Quackenbush. I do not see Jill. Monica.
Yes, I'm here.
Lisa. Lisa Schuyler. Not
I'm
seeing
not
her.
seeing her.
Nope, I'm not seeing her. And I see Amber finally got on. Hi, Amber. Hey, Amber's here. Shira.
Present.
Oh, yep, there you are. Okay. Everybody's here. Does anybody have any comments, changes, additions? Valerie.
Randy, I would like to let you know that I invited my coworker. I don't know if I'm saying this right, Amy. You let me know. You can introduce yourself when I'm done telling them about you. But ISN has a community engagement coordinator. I don't know if that's the exact term, but she'll tell you. And she's looking to learn about resources in the area. So I invited her to observe the meeting as a guest. And I just wanted to make sure that was okay.
Yeah. Who is it again that you cut out there for a minute?
Amy Cooper, and she is ISN, which is a brokerage for services for people that are developmentally disabled in 8 counties in the state, including Clatsop. And she's in charge of all the activities and joining things. And she has resources that she can bring to things. And she's going to just tell you a little bit about what she does whenever that's convenient.
Okay, I will put her under public comment.
Okay.
Anybody else have any additions or changes to the agenda? If not, I need a motion to approve the agenda with the noted addition.
I so move.
Need a second?
I'll second.
Okay, all in favor?
Hi.
Opposed? Okay, motion has passed. Okay, let's go on to public comment. Amy Cooper. You have the floor for a maximum of 10 minutes.
Thanks. I don't need that long, but I appreciate that. As Valerie said, my name is Amy Cooper. I work with her at ISN, or Support Services Brokerage, serving 8 counties in Oregon. And I am the Equity and Community Engagement Coordinator. So it's a little bit of a mouthful, I know. But really what I am doing is just making sure that that the people that we serve, individuals with intellectual and developmental disabilities, receive service equity, and also working with engaging with the community, so building community partnerships and finding out how we can better connect them to resources in the communities that we serve. And so we're just trying to establish better relationships in the counties that we work in. And so as part of that, I just wanted to learn a little bit more about Clatsop County. And so I thank you guys for welcoming me to this meeting and just letting me observe. So thank you.
Okay. Yeah, you're welcome. Glad you're here. Okay. Let's move on here. Okay, let's move on to the input for data capacity assessment, and Heidi.
Lisa just joined, but I didn't see Heidi on here. I don't know if Angie's
I don't
going to
see-
be representing. Oh, Angie's going to be representing, I think, presenting for her.
Okay.
Hi, everyone. Yeah, I'm Angie Schertzinger, and I work with Heidi Bertu Consulting as the Community Health Project Coordinator, and Carmen Gonzalez will be leading the facilitating of the focus groups. She said that her computer just rebooted as she signed into Teams, but I'm happy to get the ball rolling on it.
Okay. You have the floor.
Wonderful. So for our focus group overview with our data capacity assessment, so who here has been involved in focus groups much before? Is this fairly new for everyone, or I see Monica has? Okay, well, our focus group, it's really a guided conversation where a small group of people share their experiences, ideas, and perspectives on a specific topic. There are really no wrong answers, but we want to hear your honest thoughts and learn from your experiences. We are doing this, we're conducting a data capacity assessment to understand how data and information are currently being used in Clatsop County Public Health, and partnering organizations to identify what's working well and what challenges exist, and to find ways to really strengthen data practices, especially related to substance use. And then we also just wanted to mention that this assessment is funded by state opioid settlement funds through our alcohol and drug prevention program. So what do we mean by data? When we say data, we mean any kind of information that helps you to make decisions, support programs and services, and tell the story of what's happening in your community. So this could be spreadsheets, reports, community feedback, and observations, or any other information you use in your work. We know data can sound quite technical, so we welcome all perspectives, whether you work with numbers daily or simply think about what's happening in your community. So I kind of want to gauge from everyone what kind of comes up when you think about the term data.
Reporting requirements.
And I always wonder what the data is going to be used for. Is it going to be used for funding so we can keep doing what we're doing, or are we using it to improve what we're doing? Because I know sometimes people will say the data's used for funding to get the grants and kind of keep what we're doing, or it's used to try to improve what we're doing. So that's what I always am curious what the data, what's the reason for the data?
Yeah, so we're going to dive into this a little bit more to kind of get an idea of why we need to think about data and how you can use it in impactful ways. So some of the areas that our conversation is going to cover today are your relationship with data, how you currently use data, who handles that data work, data quality and timing, equity and sharing, and collaboration. So just to get the brain rolling on kind of where our conversation will lead today. And then we'll end up using your insights to identify priorities and recommendations. But before we get going, do I have everyone's permission to record our conversation today? Okay, I'm just going to get that going.
Yes.
Thanks, Angie. I'm just going to jump in for a minute since I was late. I
Perfect.
really apologize for being a few minutes late today. And I'm regretful that Carmen is having a hard time with her computer, but Angie and Carmen have done several other focus groups for us. And it's been really great to have a kind of third person facilitating the conversation as kind of a neutral party and then helping us look at that data. And we're excited to get back the results after this assessment and see kind of how we can leverage the resources that we have now to fill any data gaps within our department and also be a resource for our partners. So that's why we're doing this. And I'm really excited to hear your guys' feedback. Just keep thinking about data as information, which is what you use all the time in this group to kind of make decisions on what your priorities are and what kind of recommendations you're making to our department and also to the board. So thank you for participating. I really appreciate it.
Yes, thank you all. And thanks for bearing with us. I usually help on more of the tech side and the questions in the chat. So since I'm stepping in while we see if Carmen can join, I'm just pulling up our questions now so I can jump into that. So I know I mentioned this already, but to kind of dive into our relationship to data, really wanting to follow up on when you hear data, the word data, what comes to mind? Can it be, and kind of thinking around, can it be intimidating or overwhelming? Or what other words or phrases might feel more comfortable and familiar when talking about information?
Accuracy, using the data accurately for what it was intended for.
So what types of data do you use in your work or current volunteer advocacy positions?
I'll go ahead and share. So I use data to help. First of all, I look at trauma history. So I use like the ACEs and collect that data with my clients just to get a kind of an overall picture, not just for the client, but for the population that I'm serving. And then I also use data to track symptoms to see if they're how they're fluctuating.
Thank you for sharing. Anybody else?
Oh, I get a grant when I help with health insurance enrollments through the marketplace. I use data for the grant. So I do that. I think otherwise it's just looking at what's going to happen in the future. So I'm not sure how the data plays with that. More, I guess, what people are thinking is going to go in the future.
I think data is a pile of information on something, whatever you're collecting information on. But what's the most important thing is how do you get that data out of there? How do you slice and dice it? How do you do a query so you can get just what you want from all this information that's being gathered by whoever? So the reporting on that data and questioning the data.
I use data a lot in my quest for medical purposes with my daughter who experiences a disability. I just went through a whole bunch of stuff, new medical things that popped up, and that's been a constant go for me for 28 years now.
Mm.
I
Yeah,
think
thank you.
data can be used to tell a story, and sometimes it can be sliced appropriately to tell a certain version of a story, or skewed a certain way to tell a certain version of a story. So I think that looking at data really critically as we're making decisions is really important. We use data to make funding decisions and like program building decisions at CBH regularly.
Anything around substance use data specifically?
Was that to me?
For all of you.
Well,
Yeah,
I
I
would
mean, I
say-
think, oh,
Go
go ahead,
ahead.
Monica.
No, I mean, Shira, obviously you probably do too, but like, especially for those who are burn participants, we use, information that we collect, whether it be through the harm reduction program or the clientele that's CBH is serving. We use that data to help report on our burn funding.
We track a
As
lot
well
of
as
substance use
deflection.
disorder data. Yeah, and in the deflection program too. But we have a whole substance use disorder treatment team within the local county jail that we collect data on regularly. We have medication assisted treatment programs in an outpatient setting. We collect data regularly. We have 8 substance use disorder peer recovery mentors that are community based. And we track encounters with those folks, detox utilization, substance use residential utilization, kind of anything that you could think about when it comes to substance use disorder treatment, we're probably tracking it.
And then how do you use that data to inform decisions, programs, and services?
I mean, we look at trends in utilization and community need to see if the need is greater than I'm staffed at to provide, then I need to look at how I'm making funding decisions and allocating resources to make sure that I have certain programs that are, potentially staffed up. If I have substance use disorder programs that are fully staffed that are being underutilized, which happens sometimes, we have to look at that. Like, what's our outreach and engagement? Because we know the community need is there. So like, how do we fill those gaps to increase utilization? So it kind of informs high level decision making at CBH regularly.
Mm.
I have a follow-up question for that. What about for the rest of you, kind of in your roles as on Human Services Advisory Council? Is there any ways that you are using information and data, or would like to be using information and data to inform the work that we're doing here? Go ahead, Amber.
I am personally a data nerd. I love data, collecting data and using it to make decisions. And I think it would be really, important and really cool to see HSAC be able to look at, because I don't think we typically ever look at data other than when we're reviewing grants, doing the grant proposals. So if we had more data to look at to make recommendations, I think that would just improve our ability to help and fulfill our role. So I love that idea personally.
Going off of that, is there data that you wish you had access to that would be helpful that you currently don't?
I'm going to let someone else answer this because I don't want to talk too much.
I know when I help people with their prescriptions every year during open enrollment, it seems like the opioids they're not using as much as they used to, but that's just what I'm seeing. So there must be something going on out there where there's more pain management programs, or maybe there's just something else they're using that I'm not recognizing, but it does seem like the opioid use is declining for the prescription side. On the prescription side.
Oh, interesting.
And then I'll just say a couple of the things I noticed in the chat too, to make sure they end up in your recording, Angie. Amber said valuable and important, which I think was earlier for the earlier question. Then she said, I would like to see more data on how funds are utilized and various programs, and then asterisk on various programs.
Mm-hmm. Thank you for sharing those. And then within data, are there specific data sources or systems that you rely most on or that seem to be the most useful or accurate? Where do you usually go for your data?
As a provider, we go to encounter data, and then often just like specific programs are tracking engagement and utilization. Sometimes it's really old school and like Excel versions, but that's kind of what we have to do sometimes. So primarily for us, utilization shows up the most in encounter data.
Mm. And Amber, thanks for writing in the chat. I always use evidence-based data collecting tools for my own data and often research online for peer-reviewed data. Thank you for sharing. Anybody else?
I mean, I think like the community needs assessments, like that's great data, like community action, Clatsop community action, they have great data on like housing and, houseless rates and services. So, there's lots of different social service organizations that are tracking data that can inform what the community needs, where the gaps are that already exist.
Mm-hmm.
Amber, you're welcome to give as much feedback as you would like.
You must have saw my face. I was just thinking because I agree with Shira. Those like needs assessments and those tools are awesome and really, really good data. But it did make me think of like in the schools they use like the youth assessment. I can't remember what it's called. But I just know that some of the data that's out there already, yes, it does exist, but I worry about the accuracy of that data. Just because when working in the school, I just knew like that it wasn't necessarily a very equitable, like the results weren't really, it was more skewed towards a certain population. And so I think, yeah, I worry that some of the data that's out there and the way it's collected might not be accurate data. Even though I do
talking about
value
the
that
student
data.
health survey, the
Yes,
student health
student
survey,
health survey,
so
thank
survey
you.
data, yeah.
That's yeah. So those kind of data collections, like that information is super helpful, but I always look at that with like a little bit of awareness that it's likely not 100% accurate.
Or just to know what it's accurate for. Like we recently had the issue where the data was collected prior to something happening, and we were really talking about interested in data that was after a certain date. And so it was really important to clarify, you know, where there was a discrepancy in our experience to the data. And then we had a discussion, you know, being curious what was actual need now. So just to know more about where the data came from is pretty important for database decision making.
Are there individuals within your organizations that are kind of the point people to discern data? Or does everyone have a little bit of their hand in navigating data?
Or are you the only person in your organization?
Yes.
Or for several of the members in here too, they're not specifically a part of an organization that's kind of looking at this kind of public health and substance use data. They're serving in a role as a volunteer on this council to kind of make recommendations and help guide our priorities and our work. So they might not have they might be like a personal volunteer organization of one who's engaging with HSAC, which is always really appreciated.
Thanks for clarifying. It's great to have that greater understanding. Do you think that for those that are using data or yourselves, are there tools or trainings that would be useful and kind of better gauging how to use and analyze data? Or do you feel pretty confident in the use of data?
I'm just thinking back to the complexity of my research methods class in college, and just that it's when you're looking at data, there's so many different factors to be aware of to make sure that you're able to, determine if it's biased or, if it's skewed in any way. And I would think that there's probably some sort of training out there that would give kind of a wide overview that wouldn't go into the detail amount that a college class does, right? But I think that would be just helpful for anybody who's making data-driven decisions, is just to understand how to look at the data. And I'm sure there is probably a training out there that would provide that.
And then with data that's utilized in across different agencies or yourselves as individuals, are there current kind of gathered resources that you can go to and source and reference? It's kind of a shared roles and resources around data, or are there opportunities that could present themselves kind of in a collaborative data resource way?
I just go back to like the community needs assessment and the work that public health does. And that feels like a collaborative process that's reflective of a lot of different community needs that's available to all of us.
So there was a trauma-informed network that was here in the county, Resilient Clatsop County, and then some funding was cut, and there's some of us that are still trying to keep it alive, but it's definitely kind of dwindling. But that trauma-informed network is a really good resource because it's got different sectors represented. And there's been different needs assessments and surveys and things that have been done. And we have a base camp website where a lot of that stuff can be found. But it is just limited to the people that are in part of the trauma informed network. But that is one source that I can think of where I can go to find kind of a variety of data that's been collected by different types of, different people in different roles in the community.
Mm. Those are great resources to be aware of. And then what challenges do you face in managing or using data?
People change. The data might be there, but people change. And so, like the Medicare world, they try to set up different programs and say 50% of Medicare folks are doing this, but then the doctors and hospitals change, and so then it doesn't do work. So people go a different direction. It's just one example.
I would just also add the accuracy of the data. I mean, how it's collected and to Amber's point about the student ones, some students aren't going to take it seriously and some students are, going to. And so just the accuracy of the collection process.
And I think it's always, like to Linda's point, it's always just a snapshot in time. Like it's just this one moment in time when you're actually collecting that data. And so especially if you're like using data to make decisions about like future program planning or like future utilization, like currently in this climate, right? Like I've been asked to make utilization predictions for most of our programs within CBH, and we're rolling into a time of really significant Medicaid reductions. And so people are going to lose their health insurance, which means there's a large population of folks that are going to utilize safety net services. I don't know how to factor in these elements and make an accurate utilization prediction, right? So I think that again, it's a moment in time, and then there's all these other futuristic elements that will overlay how something plays out that make those types of decisions and predictions really challenging.
Yeah, sometimes data is a year or two or more old, and then all of these shifts are happening in our world today, and it's yeah, the data is not aligning with kind of where we are current in the current state of the world. Are there specific populations, behaviors, or substances for which data are especially lacking?
Off the top of my head, I just feel like some of the data that might be lacking right now for some of the underserved populations, and especially when you think about some of the populations that are feeling targeted, and so they don't want to come forward and offer information or respond to a survey because of they're afraid they might be targeted. And so I do feel like there's certain populations where we're probably not getting accurate data due to some very valid fears.
Mm.
I see that Heidi joined as well to back up Angie. Thank you, Angie. You've been doing a really good job on your own. I know there's usually two of you guys facilitating these, so you pivoted very graciously. But also, just as a follow-up question to the one that Angie just asked, is there any information about specific substances that would be helpful for you guys to know and be thinking about in order to fulfill this role with the Human Services Advisory Council? Is there anything you'd like to know more about?
I would like to know more information about youth substance use. I think that's an area that I feel like I don't have a lot of data on that I would be interested in knowing.
Thank you. Well, I'll turn it over to Heidi now and Angie.
Angie, if you're comfortable, feel free to keep going. I just heard that Carmen couldn't get in, so I left my other meeting.
Okay,
So I'm just
that
here to
sounds great.
support you. But
Awesome.
and Lisa, if you haven't already said, stay tuned to this group on that latest comment because there is a prevention needs assessment coming out with more data.
Yeah, we just wrapped that up.
Yeah, I presented on that to them last month, and I sent out the report. But there's definitely going to be more, and we have an updated report that it doesn't have different findings. It's just some of the numbers we want to make sure are right in there. Yeah, we can definitely talk about that more. But I think that report has some good data in it that Heidi and Angie worked really hard with us on pulling together.
And I know some challenges were just mentioned around just the change of the world today and those that might be comfortable with reporting and not. And so kind of curious about the data lag impacting your work and what the kind of the timelines of data being released and if you've seen that directly show up and where data could be useful for you. I think, Julia, you're talking, but your mute is on.
Sorry. It's somewhat aligned about what we're talking about. What could be useful is somebody to collect data and maybe even put together some kind of document or website that shows what resources are that we do have locally. Sometimes we're just not sure what exactly is out there, but that would be good data. In the past, there's been like a booklet kind of thing with different resources. Even if it was a website, there's a lot of different information and you can search. Sometimes things will show up. You know, somebody will tell you about something. And it's like, how could I find that a different way when we're looking for resources for somebody?
How do you all currently share data with others? Or do you find that there's someone in your community that does a good job at sharing data?
I think that in many instances, the data that we're sharing is based on at the request of somebody. And so unless we're doing it internally and then we're sharing it with those partners that do similar work. But like for a lot of what the data that we collect, we're sharing that data with the state because it's required of us to collect it.
And how do you ensure the data reflects the diverse and underserved populations that you work with?
I mean, sometimes it doesn't, right? To Amber's point. And I think that that's something, again, when we're looking at data, that's something that we always have to be like mindful of. I think especially right now, there's a population of Latinx folks who are not receiving healthcare services kind of across the board for fear of leaving their homes. I think that that will impact utilization data that could reflect in, if you're not thinking about it critically, look like a lower need potentially, right? But that's not the case. And so, again, I don't think that data always represents and is reflective of the story that we need to tell. And it's just a piece of a larger picture that needs to be looked at critically.
And to add to that, just, working with all of our community partners who we do know work with certain populations. And so trying to make sure when you are trying to collect that data, do these focus groups, similar types of things, that as a collective group, we're asking one another who isn't at the table and who needs to be at the table. So that way we can make sure that we are incorporating them into our data collection.
Mm.
And for me, I think the seniors are underserved. We focus on the youth more, and we're huge. In Clatsop County, we have a huge population of seniors. And the healthcare is difficult for seniors. But
Sorry.
that's not part of our committee, but that's, yeah.
Mm. What opportunities would you say exist for better data coordination for the underserved populations?
So I don't want to answer a whole bunch because I already kind of answered these questions with Heidi. But just in regard to trying to make sure that you know, when we're looking at how we're collecting the data, and to Linda's point about seniors, you know, we do a lot of things on social media, like answer these questions. Well, some of your older population aren't going to be on social media or aren't going to be using certain aspects of technology. Some people who are, you know, part of the underserved population might not have the resources to have those to be able to respond. So again, just working with our community partners, you know, to the point of the Latinx population right now, Consejo Hispano has those relationships so that way they can reach out to those people individually. So just again, and I think that also goes back to your question of the accuracy of the data, because when you are trying to gather this information and you're gathering it in all of these different ways, is it somehow being translated differently?
Yeah, I'll just add to that. I was going to say something very similar, like how are we obtaining the data? I think a lot of times we refer or rely on self-report. You know, you come in and take this survey when you access our services or when we have a contact with you in some way. And I think that sometimes we have to find community partners to go to those people that have interactions with them really regularly. And so that's something that I think potentially could be like, how do we access and use our community partners more often that have accessibility to some of these underserved populations? Because they certainly exist.
Are there staffing or resource challenges that make data work harder than it needs to be? Or kind of going off of what you were saying, what can make it maybe more easy to access or connect with those partners to access their data?
I feel like there are staffing concerns related to that. Linda mentioned earlier about how at different companies, like with data changes because the people leave, and made me think about how too, like some people are at an organization and they have the data and they're really passionate about collecting that, and then they leave, and there's turnover, and then nobody really knows what happened to the data, or like it loses its momentum, and so I think that I've seen staffing changes and understaffing create some issues. So
I would say, like, as the CMHP, we dump like 75% of our operating budget into direct services, and our reporting requirements are many, many, many. And, and we're a mid-sized organization without all the bells and whistles of a larger scale community mental health program who has like multiple layers of like quality and reporting and data analysts and, informatics specialists. And so we don't have those types of positions funded in an organization our size, which means that like clinical people now are also having to do like data tracking and reporting. And so like it becomes this issue of like wearing so many hats and just not even having the dedicated time to give the data analyzing and tracking the attention that it really needs because everybody's spread so thin. So it's a funding issue, I'd say, in large part.
Are there other opportunities that exist for better coordination, such as when thinking about the staffing changes or with time spread too thin that might improve coordination around data?
Well, I'd say that better coordination at larger agency levels, such as the state level, because when you are collecting data and you have multiple agencies asking for the same data in a different format, that creates a lot of burden that continues to be a problem for agencies our size, Shira size, and most definitely small agencies.
And there's like a multitude of different data reporting platforms that different state agencies use. So there's really no like streamlined process. So that really complicates things. And even different departments within specific state organizations, like OHA, for example, or ODDS, may ask for the same data spliced differently, and those departments may not even know that they're asking for the same data that's spliced differently, which puts a lot of, so when I hear data, I hear administrative burden, and it's activating for me because it feels burdensome and cumbersome, and we never really hear, I don't want to say never, we often don't hear back from state agencies on how our data is being utilized to make higher level decisions and what they're doing with the data that we so diligently report on.
Yeah, and I think, Shira, that's one of the things that I have been thinking about over the last few months as we've been talking about the CCO and the funding struggles that have been happening, is it's talking about all this data and wanting to gather data and what's the information, right? And data is certainly important and useful, but the question is, what do we do with it, right? And so many times I feel like we gather data and we talk about the data and we talk about the struggles, but what are we doing, or what, and this isn't this meeting necessarily, but what is done with the data is often part of the issue. Like, we spend all this time and money and effort gathering data and putting things together, but then what are the things within our communities, our pathways, our relationships that this data really makes a difference? Sometimes it doesn't, except be a burden.
That's true. Thanks, Miranda. I appreciate that. It's been used largely in behavioral health as an accountability strategy. So rather than like using it as a tool to inform best or better practice, or to inform service gaps, or to inform how the provider workforce, how they may or may not need additional supports or additional funding or whatever the case may be, it's been used as a tool to ensure that behavioral health providers are doing what they have been told to do.
Yeah, thank you. That's great insight.
I'm going to add something, Angie. I'm curious. I really appreciate this line of conversation. And I think I heard something similar from some nurses I talked to about this project this morning. And I think that disconnect between data being used to support communities and programs and data being used as just a checkbox tool is really important to bring up. So I appreciate that. Because we often think about, I mean, I'm thinking a lot about giving data back to communities, but also I think the folks who are collecting the data, understanding how those data are being used is really valuable. So thank you. I appreciate that.
And like what I had said earlier, is it being used for funding or is it being used to improve things? So yeah, how is the data? I think it's important for us to know how the data is being used. Otherwise, it gets frustrating, I think. If I think it's going to be used to improve things, but it's actually just going to be used for funding, and sometimes being used for funding just maintains things. And so I think it's frustrating for me if I'm thinking it's going to be used to improve rather than funding to maintain. So I think that's critical. Data.
Yeah, and a lot of times it can be used to bog systems down too, right? We know we can identify as providers in the community that there's a problem with something, and so then there's data that's done that backs that, but then all the time that it took to do all of that we already knew was a problem doesn't help resolving the problem necessarily.
So a little shift in question. What emerging data needs do you anticipate in the next few years?
I have lots of thoughts on this, primarily around Medicaid enrollment and the number of people that are losing access to their health insurance, the number of people that are having to do additional paperwork to meet work requirements, the number of people who in our community who fall into some kind of like exceptions bucket, but then how are they proving that they meet that exception criteria? What's the additional administrative burden that this is placing on provider organizations to help people navigate and mitigate the impacts of Medicaid reductions? Like all things related to HR1, I think, which is a lot. I think we're going to need data and tracking around to follow what the safety net provider impact and community impact is going to be.
Just to speak more to what Shira said, I think, in the coming years, it's going to be really important to have data, not just about program utilization, but understanding and collecting data for why programs aren't being utilized. Because like Shira mentioned earlier, it could be really easy to say, okay, this population is not utilizing services. But why? Why are they not? That's the bigger picture, right? So I think that data is really valuable right now and really important in the coming years.
And like healthcare system cost, sorry, Monica, just really quick, right? Because people are going to stop going to their primary care providers if they lose access to their health insurance, but it's going to increase emergency department and higher level of care utilization. It's going to bog down the health system in a really extreme way. And it's going to cost a lot of money, a lot more money than it would have. So I think tracking the financial impacts to health services is going to be really important.
And I think too, not just utilization, but performance outcomes. And I think that what's going to make that difficult is, especially when you're talking about some of the populations that this committee focuses on, is there's a lot of co-occurring conditions. And so when you're trying to recognize performance metrics, it's really hard when you're talking about certain aspects of the diagnoses that the individuals might be challenged with or conditions.
I think it would be interesting to find out how much time is spent gathering data versus spending with the person or with the patient or with the client. Like how much of the day are you spending working on data and how much of the day are you working with your client? Like providers. now. So much reporting has to be done. And so how much time are they spending reporting and how much time are they spending with their patients or their clients? Be interesting to see what's going on there. I don't know if that would change anything, but if you're spending over 50% of your day reporting and less than 50% with your client, there's definitely a problem. If that would change, I don't know.
Does impact, Linda, to your point, and I don't have data on this. It would be great to have, but administrative burden and reporting requirements, and at least in our field in CMHP work, has a direct impact on our ability to retain staff.
Well, and to someone's point earlier, that a lot of the data that we collect is, funding based, right? It's required by grants or it's required by certain funding sources. And as those funding sources dwindle, the amount of data that is completed will lessen. People just don't do data because it's fun to do. I mean, yeah, there's people who like it, but the majority of people do data because it's a requirement of something that they're doing, a request of somebody or a grant or whatever. And so I actually wonder what the data will we see a significant decline in the amount of data that is accessible to people based on the massive declines in funding, federal funding over the next coming years?
What ideas do you have for strengthening data capacity in your agency or across partners? I know funding is a concern. Are there focused areas of kind of tightening up procedures for data?
For us right now, my leadership team and my organization is really focused on capturing and encountering like every single thing that's encounterable. So there's a lot of contacts that behavioral health providers have with clients in different capacities. And there's a lot of documentation, and it takes a lot of time, to Linda's point. But because our funding is going to be so directly related to whether or not we can evidence our work, if I can prove that I have the documentation to justify the dollars, I have to make sure that my staff are taking every single opportunity they have to document an encounter when they're face-to-facing or on the phone with clients, which will impact job satisfaction. And there's this whole cultural shift happening around like this hyper focus on documentation, expectations around productivity because of the financial constraints that are happening within our system. I'm worried about the impacts of morale that will have on the organization, and again, job satisfaction and things like that. And yes, I think there's opportunities to capture more services, but that comes at a cost.
I know in mine, like you say, some of the tracking I have to do for the federal government. I have a couple of sons that use AI, and so they're able to put together some AI programs for me that help me track. And I just thinking there's got to be AI programs that take over that part of it. It has saved me hundreds of hours because I'm not having to track it. The program does it for me. So I'm guessing that's probably coming in the future, that would help.
For healthcare providers, there's like AI documentation services that can help with documenting and billing notes, but they're expensive. And this is software that's never been budgeted into organizations like mine, not something that we have funding for, that anybody pays us for. So figuring out how to pay for the number of licenses that I would need for the number of providers that I have at CBH is a barrier.
Well, and not to mention using those programs requires client consent. And a lot of our clients are like, no way, you're not recording anything about me and giving it to anybody. Like, you're going to give what you absolutely have to give, which I'm not sure they know what that looks like, but in their mind enough, it's to say no to AI. So
I want to, it's a lively conversation here. I have to be mindful of the time limit. And Shira, how long will your report take?
I feel like it's really going to be more conversational, and this group may want to spend like 15 minutes talking about what I will be covering.
Okay, so with that, Angie, I hate to do it, but I'm going to have you wrap this up because we still have some stuff to get to. Are you good with that, or how much more do you have?
Yeah, we're great there. My last question was just anything kind of final to add, but I think everyone contributed great, and just want to let you know that we'll use your insights to identify priorities and recommendations. The findings will help guide improvements to data capacity practices across Clatsop County and public health and partners. So yeah, you're welcome to follow up with us with any additional thoughts after today. So thank you all for taking the time.
Yeah, thank you all. Appreciate it.
Comments? Yeah. Okay, let's move on to
Lisa, should we drop,
go.
excuse me, sorry. Should we drop off? Would that be most helpful?
Yeah, I was
You
going
can
to say
stay.
thanks a lot. Thanks a lot, Angie and Heidi, for coming on, and Angie for pivoting so nimbly to facilitating. And we'll make sure to share out the report from this assessment with you guys as well when we have it.
Thank you all.
Thank you all.
Thank you,
Yep.
Angie.
Thanks again, Angie and
Bye.
Heidi. Appreciate
Take
you.
care.
Okay, let's go to old business and our membership. And Lisa, you want to talk about Nicholas Bowling being approved in the future?
Yeah. So yesterday, I presented your recommendation for Nicholas Bowling to join the membership to the board, and it didn't sound like there was much disagreement on it, and it will go to a formal vote at the next county commissioner meeting. And then
Which is on the 10th.
Yes, and then he will be in the evening at 6 p.m. And then that means that he'll be all ready to go to join the council for January.
Perfect. Thanks, Lisa. And Shira, you're up.
Okay, thank you. I'm going to try to give you a speed version, high-level overview of our county financial agreement. I did send it out or it came out with the agenda. I don't know if anybody has had an opportunity to look it over. It's totally fine if you haven't. It's really, really dense. But this document is the contract that the local mental health authority, the county, holds with OHA to deliver a set of services as the safety net provider. So that means that these are the expected services that we're required to render for folks who are uninsured and underinsured. It's a bear of a document, and there's a ton of expectations. I definitely encourage you as members of this committee to read it at your leisure, because I think that it will really help you to have a good and accurate understanding of the role of the CMHP and the expectations that we have as the community mental health program. And also know that this is only a portion of what we offer and what we're expected to do. Because we also have expectations of the CCO, we have other ancillary contracts, we also develop and build programs that just meet community needs that aren't contractual obligations. So it's a component of what CBH offers. So the county financial agreement has been in place for a really long time. It used to be the financial component of the agreement used to be broken down into what they call service elements. So these little tiny buckets of funding that were really, really prescriptive in how those dollars could be used. And they all came with their own really prescriptive set of expectations around how those dollars could be used. This time, this go around, this negotiation with OHA, we have decided to lump most of the money into larger buckets so that there's a little bit more flexibility with how counties and CMHPs can spend the money so that it meets the community needs that are actually present in a slightly less prescriptive way. Having said that, there are core service areas and priority populations that we have to fund at 100%, and the flexibility only comes where there's leftover dollars. There aren't really leftover dollars, I'm sure, not to your surprise. So a component of this renegotiation process with OHA, where we're kind of restructuring how the money is grouped, came with the request that counties or that CMHPs write local plans. So the local plan is a document that speaks directly to the contract's expectations and says to the state, this is an expectation of us, and this is exactly how we're going to meet that expectation. This is your expectation. This is exactly how we intend to meet your expectation. And here's our very complicated budget to show you how we're going to use the dollars that you're giving us and then braid them with all of the other funding streams that we have in order to meet these contractual obligations. Okay, so this has been going on for a lot of time. It's a really intensive process. I'm going to stop there and let anybody ask any questions before I move to what I'm going to ask of all of you. You tracking? Everybody's tracking? Okay.
Randy, you're on mute. Randy was talking, but he's on mute.
Oh,
sorry.
Sorry about that. Amber has a question. Section 3A1C talks about a comprehensive local plan. Where can we find a copy of that?
yeah, that's what I was just speaking to. That's the local plan that says, what are you expected to do? This is what we're doing. We submitted an initial draft that was kind of skeletal because, again, this is the first time the counties have been asked to write local plans. The expectations from OHA have been, well, unclear at times, getting more clear as we go. They're learning about this process too. The next version of this local plan is due tomorrow. And after it's submitted to the state, I wanted to make sure that you all know that I intend to submit it to HSAC. So you all have an opportunity to read through our local plan as well. You have the contract already. Now you can see this is how CBH intends to meet these contractual obligations, which again, HSAC's role is connected to the local mental health authority, which is this component of the work that we do as the CMHP. So this is really the backbone of what this advisory council kind of speaks to and needs to like really understand. So I think it'll be a really cool learning opportunity for folks as well. Heads up, the document is over 50 pages. It's really dense. The local plan is long. So just know that and, you know, read it at your leisure. There's no deadline, except to say that the final version has to be executed by the end of December. So, you know, if you have questions, feel free to email me. There's, again, like I said, there isn't a lot of flexibility in how the dollars are spent and the contractual obligations that we have in this contract. We have to do certain things. We have to fund those things at a certain level. The area where I think that this group and committee can really meaningfully weigh in is the section where they're asking us about unmet service needs and critical gaps. And that's throughout our community and within our behavioral health service continuum of care. So what I would like to do is show you what we have, what we've drafted, and then just to get your input, if there's something that's like, this needs to be there as a critical gap, I want to hear that so that I can, you know, so we can consider adding that. And then I want to give you some, you know, explanation as to why we chose the critical gap areas that we have identified in our local plan. So if you don't mind, I'll share. Randy, is that okay?
Yes, go ahead.
Okay. Okay, so this is unmet service needs and critical gaps. They are listed in order of priority, which is really hard to do. Okay, there's a lot of gaps. And I also want to caveat by saying this is not an exercise in name every single gap. Okay, I'm not writing 20 pages on unmet service needs and gaps. This is what rises to the top level, knowing that we're in a time of retrenchment. We don't have a lot of service dollars coming in the door. We need to be realistic about, you know, what can actually be done and what gaps we can even realistically meet. So I want to first talk about the
Shira,
top.
could you zoom in? Could you zoom in on it?
Maybe.
If you
Yeah.
can't, it's okay. I think it would be, yeah.
Is that better?
Yeah, that's a lot better. Thank you.
Okay, great. Okay, so our first gap that I'm identifying for the state is funding, right? So the CCOs, like as we've talked about at length in this group, they're experiencing significant funding reductions. In addition, there was a cost study, it's called the 4092 cost study, that was done to analyze how much it actually costs community mental health programs to render the services that they're rendering. That evidenced like a multi-million-dollar gap across the state, saying that the money that CMHPs have is not nearly adequate to meet the expectations that are contractually required of them. So we have the evidence to say that. That hasn't changed any sort of like funding amount to date. So the concern that I have here is that I have this bucket of money that I'm getting through the CFAA, which is this contract. In order to operate my programs, every single program is braided with Medicaid dollars or other grant sources, right? I can't run any program only with CFAA money. So now if we think about Medicaid reductions, and they're predicting a potential 30% decrease in Medicaid enrollment, my Medicaid dollars are going to drop significantly, right? Now, how am I supposed to use that bucket to prop up these other programs that I'm contractually obligated to operate, right? It's going to be a huge issue, and there is really no solve for that. My recommendation here is that community mental health programs who are pursuing CCBHC status, which is, oh my gosh, acronyms, there's too many, let me tell you. Certified community behavioral health clinics. CMHPs can become CCBHCs, which comes with additional funding, of course, a bunch of different requirements and reporting metrics, but it's really the only untapped bucket that many of us CMHPs across the state haven't accessed yet. My recommendation is that OHA prioritize CMHPs when they're considering applications of people pursuing CCBHCs to help buoy the organizations as we go through these Medicaid reductions. Does that make sense? Okay. My next priority area here is number of shelter beds. As I'm sure everybody knows, Clatsop County has the highest per capita rate of homelessness in Oregon. In the absence of meaningful shelter and housing, pretty much everything that we do as a behavioral health organization is pretty futile. People need to be housed. They need roofs over their heads, or things aren't really meaningful. We lost our funding that was operating our shelter in Seaside, and we don't have any intention of reopening that in the absence of additional financial resources. And then just the housing cost and availability of housing is the other, right? So this is true for our clients and true for our staff. We've had many folks over the past years accept positions at the organization only to not be able to find affordable housing and not be able to move to the area and have to rescind on their acceptance. Next, we have crisis stabilization centers. So for those of you who don't know, these are 24/7 centers that are meant to be a place for folks to be while they're needing to come down or stabilize or access resources that isn't the emergency department. So again, we're reducing the access and utilization of higher levels of care. It's a place where folks can come, they can sit in a recliner, they can sleep, they can get access to mental health supports, they can get some food while they stabilize and potentially get some additional support and access to resources. There's several counties throughout the state that are utilizing grant funds and piecing money together to run their crisis stabilization centers. The funding, though, it's not sustainable right now. There's not a good funding model for it. OHA is just now starting to write OARs around what's expected of crisis stabilization centers, even though some of them already exist. It's kind of messy in nature. It would be great knowing that the homelessness rate is going to increase as HR1, as we roll out all of the things that are going to come with HR1. We're going to see a higher level of homelessness. We're going to see a higher number of people who don't have access to health insurance, which is going to increase the number of people experiencing crisis. This kind of center is going to be really, really critical over the next several years. Amber.
I'm just curious if these crisis stabilization centers is there a population limit where these become mandated? It just seems kind of for rural areas that this would be a really hard requirement to meet.
So these aren't required.
Oh,
They're not required of any. They're not required of any of us. Yeah.
Okay. Yeah. I thought it was a requirement from OHA, and I thought for a rural county, that's got to be really hard. I have to leave because my client is here early. I apologize, everyone. Just want to say thank you for the conversation, and I do have one area of critical need that I just put in the chat. So
great. Thanks, Amber.
Everybody have happy holidays. Thank you. Bye.
Thanks, Amber. Thank you.
I also have to go and am putting something in the chat as well. Shira, thanks for sharing. I look forward to this local plan. And so my comment will be in the chat. Thank you.
Thank you.
Thanks.
The next priority area that we have is youth respite. Youth respite is basically families in the community that have been identified as like resource folks who offer to serve and support youth who kind of need a break from whatever their crisis-inducing situation is within their home environment. Often if youth have access to a break from their home environment to spend a week or two away, and parents can have a break or guardians can have a break, this can significantly reduce out-of-county placement, acute care placement, residential placement for young people. The funding model for youth respite doesn't entice respite providers. People don't really want to do this work in the behavioral health system because it doesn't pay sustainably. And so it continues to be a gap and has been for years. Like we've talked about a lot, youth substance disorder treatment continues to be a lacking area throughout the county. As you all know, CBH has partnered with the county and secured some opioid settlement dollars. So we do have 2 substance use disorder professionals who are in the schools now providing these services. Having said that, there's two professionals. There's 5 counties, including Jewel. All of the principals want services in their middle schools and their high schools, and even potentially some prevention work in their elementary schools, which really is more the part of public health, that piece. But the work is a lot, and the staffing for the need, I don't think is really there. So I think that continues to be a priority area for us. Spanish-speaking providers continues to be a gap. We have roughly 4,000 individuals in Clatsop County who speak Spanish. We have some providers, as you can see in our answer here, and we have really worked hard, and that's not how you spell linguistically. And so we've worked really hard to up our bilingual, bicultural provider pool. One of the ways that we do that is we offer them a 10% pay differential. So for whatever position they're in, if you speak 2 languages, you're going to make 10% more than somebody else, but we're not paid for that. There are rates that we could potentially access to help offset those expenses, but we don't have access to those rates because we're not a culturally and linguistic service provider, which is a whole different kind of classification of service provider that you have to be through OHA in order to access those enhanced rates. The last here is lack of primary care with specialized training and working with people with severe and persistent mental illness. So folks that our most acute clients, they're assigned a PCP because if they have Medicaid, because everybody with Medicaid is theoretically assigned a PCP, our folks tend not to go to their primary care appointments because the medical model just doesn't meet their needs. The appointments are too short. They don't necessarily have trusting built relationships with their providers. It takes a lot of rapport and conversation and trust to get somebody who's severely psychotic to sit through a medical appointment. these folks often have trouble identifying and expressing what their needs are, what their symptoms are. Their physical symptoms often end up being kind of attributed to their mental illness, and then their needs aren't captured or taken seriously. And there really isn't a specialized group of folks who know how to work with this population. CBH would love to have some primary care providers internally that know how to work with this population. There aren't currently any funding sources that are built to allow for that type of integration for behavioral health as the primary, to hire primary care providers. There's some reverse integration that allows for behavioral health providers to exist in medical or primary care settings, but not the opposite. And that's all.
Okay.
So, thoughts, feedback.
Okay.
I have a quick question, Randy, and just a clarifying question to the group. Shira, can you confirm this is just if we have money left over, correct?
No, we don't have money left over.
No, no, we don't have money left over, but this would be our local plan that if we had money left over, this is what it would go towards?
Yeah, this is saying that as a community, if there were ways for us to start meeting gaps, that this is sort of the order in which we would address those gaps.
Yes,
But
thank you.
knowing that none of these expectations or needs are going to be met by the dollars that are currently connected to the CFAA.
Yeah.
Okay. Any comments or questions for Shira before we move on? If not,
I have one. Sorry. I know
Okay,
this isn't
go ahead.
really directed to me, but I did just think of something that I've heard from community members that kind of ties into your linguistic kind of competency one. And I've heard from folks in the community who are Spanish speaking that the screening tools that CBH is using are not really culturally specific. And so sometimes they feel like they're not being asked the right questions to gauge their to gauge like what their problems are necessarily. And so I've heard that a few times, and that might even, I kind of wonder if those tools are actually ones that you're like required to use, you know, by the state in order to find out if people are eligible for programs. And I don't know how the process works at all, but I don't know if this is a space where you could, or if there is any space where you can kind of voice that concern to the state that some of like the criteria requirements that they're, you know, making you guys follow for allowing people into programs or to receive services are not kind of culturally specific enough to be catching the needs of specific populations. And I can't speak to it any more than that because I don't understand how your process works. but
I think,
you know,
Lisa, if I knew like
ties in with
which tool you were referring to, that would be really, really, really helpful, because there certainly are things that we're required to ask at intake, documents that they're required to sign by OHA. And then there's also clinical tools that CBH has developed, and it's entirely possible that we need to make some improvements around making sure that they're like culturally responsive and appropriate. But I don't know what piece is feeling that way for folks. And so if there's any way for you to get any more clarity, you can definitely get with me offline, and we can, because I'm saddened to hear that, and I want to do a better job.
Thank you. Yeah, I appreciate that, but I thought that might be something that tied in with that gap.
Certainly, there's definitely a lot of expectations that are embedded within many of our fidelity programs that are not culturally responsive or appropriate, that are OHA expectations, and they do hear that from me regularly.
Good. Glad you're expressing that.
Okay. All right. Any other comments or questions for Shira?
Yeah,
before
Shira,
we move on? Grant.
Shira, is there any way you can send us out that portion of your report that you just went through with us?
Sure.
I saw it was like a 30-page report, but just those 2 pages would be great.
Yes, it's 50 pages, but yeah,
Okay.
I'll send you just these two. Certainly.
So is that the report that was attached that Lisa attached? To our-
No, what's attached is the contract itself, which says this is what CMHPs are required to do as a
Gotcha.
CMHP. This is our response to those contractual obligations.
Okay, yes, if you could send that out to us, that would be great.
I'm going to send the whole document after we
Perfect.
submit it to OHA, probably early next week. So Grant, if you want to just wait for the whole document, I can just do that. Or I can just save a couple of these pages and I can send them to you after the meeting. It's still in the works. We're like, we got 5 p.m. is our deadline tomorrow and we're putting finishing touches on this version. So I want to send it to you when it's formatted and readable and has a table of contents.
Yeah, I can wait till it's all. If you want to
Okay.
read it all.
Great.
Okay, great. Thanks, Shira. That was interesting. Thanks again. Okay, let's move on to Commissioner report. Commissioner Thompson is out of town, so she's not here today. So we'll move on to the next meetings. And I believe it was Monica and Shira requested a change of meeting date to the second Thursday of the month beginning in January, which would be January 8th. So I would like to take input from our members on if that works for you.
Can I add a little bit of clarification why that request was made?
Yes, please.
And kind of to the point that Shira just talked about with the local plan, really trying to more heavily utilize the HSAC committee in this role. And Shira has a standing meeting that she's had since before she took this over for Amy. And so it makes it challenging sometimes for her to be able to be to this meeting. And so that's why sometimes she's had Stacy come in her place. And so that's why the request was being made to accommodate that other standing meeting that she has.
Thank you for the clarification. Okay, so I'll pass it along to our members.
So Randy, I can do February on, but I already have an appointment I can't get out of on the January 8th, but otherwise I'm fine.
Okay.
I'm fine. It
Okay.
doesn't matter to me.
I'm fine.
Yeah,
Julia, Grant.
I'll do my best.
I'm good. I know we were never really going to do it on January 1st anyway.
Yeah, but I mean, it's in the future going forward as well.
Yeah, I'm good with that.
Okay. Valerie, are you good with that?
Yep.
Linda left, so we don't have a response from her. Or is she still here, or did she leave?
Linda Whitney's on here.
Oh yeah, Linda. Sorry.
And I said I'm fine.
Okay, great. And then Miranda left and Amber left. Okay, I'm good with it as well. It doesn't matter to me. So let's take a, well, geez, I hate to. Yes, if they
We can
can't.
we can follow up with, is it just Amber and Miranda who aren't here?
Yes.
And so
And
Lisa,
with
do you
Nicholas
think
also, the new
yeah.
person.
Yeah.
Yeah, and
Would
then
you-
then we got that as well. Lisa, how about this? Lisa, do you want to send out an email to just the members and with this, and then we can see what Miranda and Amber think about this as well before we decide. I'd hate to take a vote right now and leave them out and have them have to drop out for some reason if they can't make it.
Yeah, I can send an email after this meeting and just double check that second Thursday will work for them.
Okay, and then once we all reply to that, then maybe you can send it out to the whole group and we'll go from there. Does that work?
Sounds good. Yeah.
Okay, all right, let's do that then. Okay, and then
Sorry, Randy, before you adjourn, one
I'm not
person
adjourning
that-
yet. I'm not
Okay.
adjourning yet.
But before you move on past that, Lisa, I forgot, I don't know if you followed up with Commissioner Thompson, but we'll want to check with her as well.
Oh,
Yes.
thank you. Yes.
Yes.
That's also
Good.
important. Yeah, I'm putting her on
Yeah.
my list.
Good point.
I think
So-
she has a standing meeting at this time, maybe on a quarterly basis, which is why she's not here. So it might be good for her.
Okay. All right. So with that, then the proposed topics for our and CVH Community Health Plan. Is there anything anyone else wants to add to that? Okay, doesn't sound like it. So we'll go ahead and we'll move on with this with Lisa's email, and we'll decide after that what we're going to do. And with that, let's move to the good of the order. And I have one thing, and I just want to throw this out to Amy. Amy, what'd you think of our meeting? Or is she still with us?
I'm still here.
Okay. What do you think, Amy?
I feel like I learned a lot. Thank you guys for having me. I appreciate it.
Okay. And to attend any other time.
All right, thank you. Appreciate that.
Okay. Anybody else, anything for the good of the order? If not, we'll go ahead and adjourn, and it is 4:30. We met our time limit. So thanks, everyone, and
Thank
we'll be
you.
chatting soon.
Bye.
Bye.
Have a good night.